Question for the last speaker here. What kind of technology are you using for the data integration for healthcare exchanges?
So there's actually three things that we're using on the healthcare exchange data. There is a virtual services exchange infrastructure that Cisco's built for media and entertainment. So we're using that as kind of the basic framework. So what that basically is cloud computing, and it's built on a lot of the principles of what we've acquired through WebEx. There are applications, however, that we've put on top of that that use the integration of the medical records specifically. So in Europe, for example, they're using Tiani Spirit. Tiani is one of our partners here in the US. So the concept of putting applications on that infrastructure is something that we're starting to see as a way to adopt that technology very quickly.
Any other questions? If not, we have a break, correct?
Question here?
This might seem like a really superficial question from the medical perspective, but from the patient perspective, I'm interested. I know there's a lot of research going on at Carnegie Mellon about how we interact with robots based on their aesthetics. Why do we trust a robot? Why do we have empathy for a robot? Why do we give authority, clout to a robot? And when I see that Da Vinci robot as a patient, it scares me. and I'm wondering from the patient perspective, is there any intention of creating robots that make the patient feel safer or more warm and fuzzy than institutional? Are those kind of questions being addressed?
We're going to give this question to the expert who is
a robotic expert. But I share your concern.
That's a great question. One of the amazing things to me when I look at Intuitive's history is it's actually patient demand that caused the success of the platform. You can't get your prostate taken out these days without a robot. You don't see the robot really. You're under anesthesia. So, but yeah, no, it is pretty amazing. We haven't paid much attention to the warm and fuzzy design factor. In all honesty, it's mostly been what are the mechanical constraints that the surgeon would be most comfortable with. How does the OR staff interact with the robot? It's, you know, in most cases, you may never see the robot unless you actually, if the surgeon takes you on a tour and shows you. You know, much like surgery, you kind of take some laughing gas, then you wake up on pain pills. So, but that's an excellent question.
Any further questions? Frank, anything for Frank?
I think actually just add a comment in the sense of this warmness. This is a clear example of what the Omron cat robotic, which is based on the sense and warmness, and then you have the Sony dog, which is a robotic shape in a sense, but is a more intelligent one. And there's a lot of study has been done. And again, you have the Azimo one, which is a Honda one, that they look at, okay, what are the people want from these things? So the kind of survey was different. Because sometimes you need some companion, but sometimes you want some intelligence, and then there's a trade-off between which one you actually prefer to that one. And if you go and survey the Omron cat, it is pretty much a realistic, warm, and fuzzy, and everything else. But when you look at the dog, it really is a kind of a robotic, but they're most acceptable.
Excellent. We have another question here.
Hot? Yes. With the diverse experience of the panel, I'm wondering, are there any incentives in the United States and even Europe to implement technology that delivers the same quality, same capabilities, but at much lower cost?
Well, I can take a portion on that. Well, if we are talking about healthcare IT specifically, you know, there have been incentives in order to make sure that, let's say, the CPOE adoption, which is computer physician order entry, to make sure that, you know, mistakes are not making, or the entry is even more efficient and reduce costs, as Ash said. So yes, there are different incentives worldwide in order to push those technologies forward. Ash, anything additionally?
Yeah, I think that in the US we're seeing really three kind of things happen with the new accountable care organizations that are emerging here. the financial risk is going to be on the burden of the provider organization. So they're going to be incented to use these kinds of capabilities to begin to extend their reach and lower their unit cost. Now, we are doing probably most of our advanced research in India and in China. So the model I showed you, the high-end health presence, was actually deployed on a WebEx using a laptop, with a laptop camera with the devices in India already 2 years ago at a very low cost. That is not FDA approved yet here in the US, but we're working on it. And in China, we just did 2 tours with the Chinese mayors, 32 mayors across China. And their goal is to have a visit that costs less than $1. So to your point, that's really where we're going, and I think we're going to leverage our teams in the emerging markets to help us get there.
Thank you.
A question about the technology to move the data. So you have the truck in China or the telepresence, but you need to move heavy data over long distances.
Yeah.
So what is that Cisco is using now, and what do you know about technologies to move big data for medical purposes?
Sure. So the concept of the movement of data is something that's a very important part of the principle of the network. So the first part of the principle is we don't move the data. That's the first part. The second part of it is you need to personalize it and make it accessible to the people who have access and block the ones who don't. So what we've seen is there's a whole concept now of virtualization of computing, which basically allows the data to remain resident, allows it to be viewed and accessed to the appropriate individual, and it allows it to remain in the same location, and actually it even allows it to get aggregated with other sources of data. So the whole concept of the virtual services exchange, the medical data exchange, is built on that very principle. Now, there have been new computing capabilities within the last 3 years that allow that to happen. The concept of the unified compute infrastructure, that was a big breakthrough within the last 2 years. We're seeing a massive adoption of that worldwide. We're also seeing the concept in healthcare about radiology images, for example. That's the use case. Once you start moving radiology images, game over. Can't do it. Radiology images need to remain where they are, and you need to be able to access the images, the studies, without actually moving the data file. Think of it when you go on the web and you view a YouTube video. You don't download that video on your device. You just view it. That's essentially the principle behind the healthcare medical data exchange.
Excellent. Thank you. If we don't have, another question?
Yeah, this is really related to the previous ones. The WebEx version that you're using in India or China, is that the same that we have access to here commercially? Because we use that a lot in our business, but it's too slow.
There might be some interesting discussions about why it's slow. We can certainly talk to you about that. But it is exactly the same version. We actually have a company here in the United States called EmergeMD that is based out of the Barrow Neurological Center. They actually built a whole clinical workflow on WebEx for neurology consultations. So there might be some other reasons why it might be behaving in a slow manner, but the general infrastructure is one that we use extensively. As a matter of fact, we've actually canceled all of our global meetings now. We do them all on WebEx. We've had about 15,000 people logged in simultaneously around the world using the real-time video capabilities of WebEx. So it's, we'll definitely, I'm happy to get one of our engineers, Morgan Morris, who's on our architecture team, can certainly help connect us with the right people there. Thank you.
Excellent. Thank you. Excellent questions. So many thanks, Jonathan, Frank, and Ash.
Thank you so much.
Thank you.